I might add. Ins and outs of probing, and this is the when, where, how, what, how we go about it, okay? So learning outcomes, I'm sure you've had a read of this when you registered. I think you get some CPD, maybe. But indications on the challenges of probing around implants, how often you should do it, why is it different than probing around natural teeth, and then a little bit on the technique for probing around implants, and know the features you're looking for when you're selecting a probe. So very simple here, and the implant examination, there's a lot more to it than just probing, but we're just going to focus on that today. So the indications for probing, so as dental hygienists, periodontists, general dentists, it's within our remit and our scope of practice to actually carry out a holistic, comprehensive oral examination, and that includes all the structures, be it restorations, implants, and the soft tissues in your examination. So it's, if your patient's got like 26 teeth and 2 implants, you can't really ignore the implants, okay? Bit of an issue with probing around implants is it's just one of those things that is not covered extensively in the undergraduate curriculum. You may have been lucky and had a little bit of a practical session. Exposure to patients with implants is usually reserved for specialist training, those who are undertaking an MSc in perio. So we kind of save the juicy implant patients for those students. So it's mainly part of postgraduate training. So the incidence of peri-implant diseases, we know that implants are susceptible to complications and peri-implant mucositis and peri-implantitis. The treatment of peri-implant diseases is unpredictable when you have deterioration of the bone, the alveolar bone. So non-surgical therapy is perfect for peri-implant mucositis, which is the gingivitis around an implant where the lesion is confined to the soft tissue. Peri-implantitis treatment is a lot less predictable, more complex, and there's a much bigger financial investment and time investment for the patient as well. So it's really important that we nip these things in the bud, and if you look at the guidance from the EFP and the AAP, primary prevention is the best solution. So get in early. So and also carrying out an examination on a regular basis of implants, be it a verbal examination and intraoral, also helps you to identify any maybe new risk factors that the patients have developed, or any new habits. Maybe they started smoking or under a lot of stress, etc., etc. And then one of the other reasons it's really important to do a really comprehensive examination around implants is because there's a lot of litigation around undiagnosed and untreated periodontal disease and peri-implant diseases. So failure to identify a problem and then failure to act on that problem once it's been identified. So you may document that there's bleeding on probing or an increased probing depth around an implant, but failure to actually do something, so you need to document in the notes and follow those patients up. And then the last little bit, it's a bit controversial, to probe or not to probe, and who's allowed to do it, and what can we use, and is it safe, and what are we going to do? But if it's not you, then who's doing it? So if you have this philosophy in the practice that everybody who sees the patient, the patient's care falls under the umbrella of everybody in the practice. So we're all responsible, we're all indemnified, and no matter who's treated the patient, if you've touched the patient, it means you're implicated. So really, it's very important that you're doing this on a regular basis. And, we're doing it for the patients, right? At the end of the day. So maintain teeth, dental implants, restorative counterparts in health, aesthetics, function, and for the duration of the patient's life. That's why we were all put on the planet. That's why we're here, and for no other reason. So what are the challenges? Okay, I'm going to whistle stop through this, okay? So the shape, as you can see, the bulbosity of some of the restorations make it very difficult to not only probe, but to clean around implants, okay? The shape, so here all looks hunky-dory, doesn't it? And you're imagining that the lines will actually follow. You adapt the probe and insert subgingivally, but actually if you strip the gingiva away, this might be what you're looking at. So bulbous crown, and then a very narrow abutment or collar that you're trying to get to. So you're like trying to play snooker, right? You're snookered. It's like a curved ball to get to the abutment where you need to probe. Sometimes implants are too close together. You find it really difficult to get the probe in there and navigate around those structures. The position of the restoration as well. How close is it to the alveolar ridge? Could you get anything in there? Not even a wafer thin mint. Do you even know where the abutments are here? Let alone the poor patients trying to figure out where they are and how to clean them. So there's a big drive now to have prosthesis and restorations that are cleansable. If they're not cleansable, then it is a recipe for more disaster. And it is very difficult to, really try and get a patient cleaning around these areas. I love Optrogate, by the way, for these cases. I use an Optrogate, put it in, show the patient how to clean, and then I show them how to put it in themselves. I give it to them to take home. They last forever. They're not biodegradable, so one will last forever, and the patients can have 2 hands to get their super floss or their proxy floss or their little pokey things in underneath those restorations. I never miss an opportunity to do oral hygiene advice, by the way. And if the patients can't get in around those prostheses and you actually are in a practice where they can take it off for you so that you can get in around and clean it up, sometimes this is what you're faced with. And again, trying to get around those fixed prostheses and getting into these very narrow spaces to actually get your probing your pocket depths. So exposed threads are another problem as well. So once you've got exposed threads, the geometry of the surface makes it even more challenging to collect data around those areas. Ill-fitting crowns, you've got these like little ledges and edges which are also plot retentive. Excess cement may obstruct the probe going subgingivally as well. And here's some excess cement here. This is just one example. And also customized attachments as well. So, some of us are filled with dread when you look in the oral cavity and you see these kind of structures like these header bars. So these are customized. So there's kind of only going to be ever one in the world of these. But they're sometimes very, very difficult to get in around the tissue, particularly if the patient's not cleaning underneath those structures, those attachments. The tissue becomes very inflamed and it also becomes quite fibrotic as well and pushes up against the header bar, so the space is actually really, really tight, and then it makes oral hygiene even more complex. And again, there's my Optrogate, okay? And then altered anatomy. So I work in a head and neck cancer clinic on a Thursday morning at Guy's Hospital, where I'm based, and we see lots of altered anatomy. So you might look in and see this and go, oh, how am I going to go in around that? And that can be a little bit frightening as well. And you go, oh, will I actually cause more harm than good getting in there? These particular patients rely on these restorations to restore their self-confidence, their ability to eat, especially if they're going through cancer treatment. The other thing I've noticed with these patients, and these are zest locators, so for implant-supported overdentures. So a lot of these patients have had ablative surgery. They find these really difficult to clean around and they're quite nervous. But another thing these patients suffer from is xerostomia. So they've had radiotherapy, chemotherapy, and dry mouth. And dry mouth means that they get a lot of debris hanging around. And all my implant patients all have water picks, particularly if they're head and neck cancer patients, because they like that really fresh washing everything out of the way. It really helps because it gets quite sticky in there. So the perimucosal seal, this is kind of probably the most controversial bit. So, probe, don't probe, and why would you not probe? And any implant placing people here, doing the surgical side of things, the perimucosal seal is the artificially created junctional epithelium, okay? So the attachment has hemidesmosomal attachment to the crown, but it is not as structured or robust as it would be around a natural tooth. So it is an altered periodontium, which we call the periodontal or the peri-implant tissues. So it's very important that you're, being very gentle and careful and very controlled probing and taking data from these areas. So you want it to, really maintain that seal. You don't want to be penetrating through that seal and introducing oral pathogens into what was a nice, tidy, clean area. However, there is research and actually Klaus Lang, he's here, I spotted him yesterday. Love that man. He's married to a hygienist, by the way, so how could you not love him? So he did this really interesting study. Actually, this was done in dogs, and this was where they probed through the perimucosal seal, and actually it was completely re-established and the same as baseline pre-probing within 5 days. So it's not like you probe this and then it never ever heals and reattaches ever again. And probing, well, should we be doing it? Well, to probe or not to probe? I'm so confused. I don't know whether I'm coming or going. But if you go and look at the EuroPerio10 guidelines for the first time ever in the history of the entire world, we have a new classification for peri-implant diseases, and it is worldwide. So it's AAP, EFP. We've all come together and tried to standardize what we're looking for. So you're all familiar with this document, but I've just pulled up a couple of little things here just to, do I really need to probe? And if you need to justify this in your practice to your principal, your dentist, your periodontist, whoever you're having a squabble with about probing. Okay, so bleeding on probing. You don't know if it's bleeding on probing if you don't probe. If you don't go, you won't know. And probing depth, okay? Now, how many, are we doing a BPE, a screening, a PSR if you're in the United States, CPITN around implants, or are we doing something a bit more accurate? 6-point pocket chart. So if you look at the guidance, however, 6-point pocket chart is not always achievable around implants, okay? But you do the best you can, okay? You'll aim for 6 sites, but you'll get as many as you can. And actually, Lisa was online yesterday. I believe she had some problems with her presentation, but I follow Lisa very closely. She's a professor in Australia, and she's done loads of work on peri-implant mucositis, and they're like really nice papers to read if you're like suffering from, you know, I don't know enough about peri-implant diseases. They're really well written and really nicely laid out, and it makes perfect sense. And then the other thing I just want to point out is that if you just look at this, you might look at that and go, actually, that tissue doesn't look too bad. But visual inspection can be deceiving, all right? Yeah, well, it's red and blue, but they might say, oh, that's a nice tight cuff. Actually, I won't go poking in there. Well, let's not cause any tissue distension in there. But actually, you know, there are things going on there, all right? So it's very important to just probe, because a palpating an implant will tell you so much, and then a visual inspection will tell you so much, and then you gotta pick up a probe as opposed to a penguin. Okay, why probe them differently? Okay, so they're not the same, okay? They're self-explanatory, okay? The surface, the anatomy, the geometry is completely different. So why would you take things that you use for that and use them on there? Same as when it comes to hand instruments, ultrasonics. You know, you don't debride that the same way as you debride that, because it just doesn't work. They don't adapt, being the key word. So let's have a look at what's different. So you got periodontium, we know you've got your 4 components, and then with the perimucosal tissue, so we don't call this the periodontium, it's perimucosal tissue. You've got the gingiva, you've got the alveolar bone, so you're missing your periodontal ligament fibers here and the cementum, so that anchoring. If you look at the structure here of the fibers, you've got those supercrustal fibers, and they're parallel to the surface of the implant. But you're missing these really important ones, which are perpendicular, and they're really important for anchoring and support. Plus, they provide a line of defense against bacterial contamination. So these provide, so you've got to get through many more layers, like a cross-hatching layers, to get down to the alveolar bone and break through that periodontium than you do there. It's much faster. So the rate of progression of implant decline is much faster around an implant than around a natural tooth. And this is, again, just to show you the difference in the structures here, okay? So you've got these lovely fibers going parallel, but then what happens when you probe? Well, this is the tooth here on A and C. These are the fibers jutting out at right eye. So I'm the implant. These are my perpendicular fibers, okay? And then this is the tooth, I should say. And then this is the implant. The fibers are just running like this. So it means there's a very... a great opportunity there to actually detach and break the attachment, okay? So this is what it looks like. This is a bit blurry. I do apologize. So this is when you're probing around a tooth, you'll feel that resistance at the base of the pocket, right? The junctional epithelium. For an implant, you're looking for the base of the sulcus. However, if you don't have a fulcrum and a really steady hand and a nice thin probe, you could very easily penetrate down there. Now, I have heard millions of times, don't probe in case you hit the alveolar bone. Hasn't happened yet. Okay, so when should you do it? Baseline, and when the restoration has been fitted, and then every 6 months. And then you need to really evaluate it on a patient-by-patient basis. So you don't want to over-probe, but you don't want to do it, so infrequent that you're not getting data fast enough that will inform your clinical decision. So annually, in the absence of any signs. So these are all coming from different areas, but I like to review them at every single time I see the patient. So I will always do a full examination every time I see the patient. Patient comfort, really important. So they don't really like probing, do they? No, they'd rather have a baby or have their eyeballs gouged out with a blunt sickle scaler. So patient comfort's very important. What grading are we looking for? Well, if we're looking for a 6-point pocket chart, why would we use a probe that's a CPITN-C or a CPITN-E or a WHO probe or a BPE probe? Because then you have to guess a little bit. So you're going, well, is that a 2? Is it a 3? I'm not sure. This one is more accurate, so you want millimetre by millimetre increments on your probe. So you can have a little go with these. So these are the new Deppeler UNC15 probe. They are made of PEEK. It's a flexible thermoplastic. And the markings have been lasered on. It's very flexible. It's your flexible friend. And what you want to think about is, I need to be able to go around corners with this thing, okay? So it's like playing snooker, okay? So I need to get, this is the abutment, that's the crown or the prosthesis, and I need to go from there to there, okay? And my name is not Ronnie. So this is remember, you got to get around and adapt and then get down there. So it's easier said than done. So you want something that's ergonomic and really light, that encourages a really light grasp and a very, very light fulcrum as well. This one's got geometric pattern here, and usually the thumb and the index finger will sit there. This is the CPI10, and then the UNC is coming up. It's very light, and it's carbon fiber handle, and here I am with one that I've labelled so that you can't steal it. And it's in green because I'm Irish. And then this is the modified pen grasp, really light. But the very important thing when it comes to probing implants is your fulcrum, because the fulcrum is what's giving you the stability and the control to get that implant probe down there without penetrating through the perimucosal seal, and we'll all die. Okay, so adapt. This is if you want to learn some more things about probing. It's like, who knew there was so many things to know about just probing, right? But it's adaptation, insertion, paralleling, and walking. Parallelism is a word we love to use in probing. Okay, so adapt the tip to the implant. Always make sure the tip is engaged, and then keep it parallel and in contact with the implant all the way down subgingivally into the sulcus. We don't call it a pocket, we call it a sulcus. And then advance apically until you feel that resistance at the base of the pocket, and then you're going to walk along the floor or the base of the pocket, okay? You're not going to come out and go back in again and come out and go back in again. You're going to stay in, more comfortable for the patient. If you take 6 sites and you mesial, that's a 7, and that's a 5 on the buccal, and the distal is a 3, then you're actually stabbing the patient 3 times when you only need to stab them once. And then you exit. So angulation about 0 degrees. Try to keep it adapted as much as possible. Keep it parallel to the long axis of the tooth. So this is what it should look like, and not that, because your reading will be incorrect. And then the pressure should be about 15 grams. So if you look at all the literature for probing around periodontal tissues, it's about 20 to 25 grams. When we were students, we were like, what is that? It's the weight of a packet of crisps. So this is when you can depress the pad of your thumb. Give it a go. Okay, depress the pad of your thumb, and you should see 1 millimeter, and that's how you know that's the pressure, and it's very light. Or just depress your thumbnail, and as soon as it blanches, that's your pressure. Okay, so it's actually very light. Now, the other thing you'll notice about this probe is it's super thin, so it's much thinner diameter than the other probes that I've used. And then you're going to walk. Why would you walk? So 2 reasons. First one, you want to be comfortable for the patient, but the second one is you could miss a very narrow vertical defect if you come out, insert mid-buccal, and then go back into the distal, okay? So that's another reason why you would walk along. So, and then we should have this should play, I hope it'll play. This was like, midnight in the kitchen. Hello, my darling. And then just bobbing up and down. So you're bobbing up and down, going down to the base, and then out. Okay, and you have to tilt to get in underneath those contact points. All right? And we'll move on. So interproximal probing. So again, getting a correct reading. So you need to tilt the probe as you would do in a perio probe. 6 sites, we all know what they are. And just a kind of a little reminder for you. And then always combine. Always combine. If you pick up a probe, always do a bleeding score. I do a bleeding score for every single patient, and it's a great motivational tool. They like numbers, they love visuals, and give them a risk assessment. And this is one of my top 5 patients. All the patients like to get into the top 5. My best patient is 0.8% bleeding score at the moment. That's my record, and it's not your patient. So combine it with a bleeding score, because you want to know what's happening around those implants, and then increased pocket depth, probing depth from your baseline or 1 year after the prosthesis has been restored, because you'll get a little bit of settling in. It's like wearing in a new pair of shoes, right? They're really hard, aren't they? The first day, it's like, oh, and then they settle in, okay? So the bone will remodel for the first year, and that's pretty much acceptable, around 1 mil, 2 mil maximum, and then that's it. It should stay there. Your probing depth should be collected at that point, and then that should be your baseline. And you need a point of reference if you're probing as well. So it's very different around a natural tooth. You've got the point of reference as a CEJ, a non-movable point. So you've got to find a fixed point of reference on implants. So go from the incisal edge or look at the first thread, and then document in the notes that that's your reference point. And then obviously trying to reproduce the radiographs at the same angle, and we go for PAs and a paralleling technique. And that's all I have to say. That's it. Thank you for coming. Any questions?
Where would you generally put your point for the fixed point when you're measuring
for the 6-month pocket? I would go for the incisal edge, and that's why you need a UNC 15 probe, because a Williams is not long enough.
15.
It has to be 15. Any implants. So from now on, actually, in practices, you're going to see this mixed, we'll say, dentition. There's going to be a mixture of implants, and you can't escape. And a UNC 12, a Williams, they're not going to cut the mustard anymore. It's always going to be UNC 15. The beauty of this is I use this for implants and all my other patients, the normal ones. And it's softer and rounder and smoother and thinner, and it doesn't hurt as much as using a metal probe. And the other thing is it's smooth. It doesn't have those indentations in that you have, which actually are jaggedy. And if you're putting those down, and they actually hinder your ability to detect calculus. So you want something smooth and flexible so that you can actually really pick up those minute details on the root surface of the implant surface. So patients actually prefer this, and it will force you use a lighter pressure. It will force you to have a lighter pressure. You're just not going to be able to ram it in, all patients. So I've got one of those in every kit. And metal probes, out the window.
I hope someone hasn't already asked this question. But the markings on there.
Yes.
Because with another leading brand, the markings go very quickly. Right.
So you can rebuy I'm not sure how much they are. They could be, I don't know. I'll just pull a figure out of the air. 20 quid. I haven't a clue. But you can replace them. Okay, now I'm not sure about the length of time, but I know that these have been through rigorous testing over and over and over again.
And actually we have the 3, 6, 9, 12
yes.
for so many years.
Yes.
And I've never had one that came back because it faded out. It never fades out because it's inside the part.
And I have that probe too. I've had that probe for about 6 or 7 years now, and they're still absolutely perfect. So we don't have a problem. If you have a problem, you contact her, not me. But yeah, at least you can replace them, you know.
Yeah.
And they also do this. This is actually a mirror handle as well, which is quite nice.
It's the diameter as well is nice.
It's really thin. What I notice with other probes, and I'm not into, I'm not going to slate any brands or anything like that, but other probes that I've tried, they're much wider, so they taper, but they actually increase much.
That's what we have.
Yes, so they increase much faster. This actually is pretty thin all the way up. So it is the thinnest one I've found, and it's nice and flexible. But you've got to be really careful with these. These won't take hacking. You can't be going around with these in your pocket, and sit on them and stuff like that. And they are not for RCTs and plugging gutta percha. Oh no, they're not. They are literally a ruler, okay? So they're a measuring device, and they're for that and that alone. They are not for any excessive force or any restorative procedures, or they do not use them for removing excess cement, which was one of my jobs when I worked for Dr. Cleary. All right. So, any more questions? Anything? Anybody? Anyone? Thank you so much for coming.
Better than the one I use at the moment, which is the BDC.
No, it's UNC 15 all the way.
Yeah, totally. And and we had a Williams in Dublin, if I recall. So I'm not sure what you guys.
UNC 15.
Oh, hallelujah! And the same at King's. We have a UNC on one end, and we have the CPITN on the other. Because some students, if they're in restorative, they get asked to do a BPE, and if they're in perio, we do 6-point pocket charts.
I did order the BPE ones recently just to have them for our own practice. But this is the.
Yeah.